Plumas County Public Health Agency, growing healthy communities.
It's a pleasure to be here. I want to just start by saying that, I was reflecting with some of my colleagues over lunch that I've spent the last 10 years in New York, but I've spent the last year and a half in California, up and down the state, and listening to people who use drugs in communities talk about what services they need, talking to providers about what training and capacity building services that they need. So I feel very immersed right now in sort of what the experience of people who use drugs has been in California. And we saw a video earlier from Dan Big, who passed away last week. It's a very heavy week in the harm reduction community this week. And it's really nice to be here and to hear so many people who are passionate about learning and making a difference in their community. So thank you for that. I've really enjoyed just the conversations I've had so far. And I also hear that people kind of want to learn the stuff, like what's the stuff that harm reduction is? How do you get started? What are the actual nuts and bolts? We'll talk a little bit about values, but I'm really here to talk about what we have learned over the course of decades in the harm reduction movement about the power of centering people who use drugs in programming, and some of the practical tips and tricks to make that happen and create not just good public health interventions, but really shape and build a movement. Oh, the clicker's not working. Let's see. Okay, but before we do that, I need to tell you a little bit about Harm Reduction Coalition, because we offer some tools and resources that I think might be helpful for many of you here. So first and foremost, I'm gonna click, they'll start appearing like magic on the screen. Yeah. So Harm Reduction Coalition is a national organization. We oversee policy and capacity building services across the country, and really work to identify what the community needs are, synthesize all of those themes, and do national policy and advocacy work. We aim to promote the policies and programs that support the health and well-being of people who use drugs and people who engage in sex work. Now, I'm saying people who use drugs and people who engage in sex work intentionally. Have people heard of people first language? Hands? Yeah. So, people first language is saying a person or people before the behavior. And the reason that Harm Reduction Coalition uses language in that way is because people are people first and drug use is secondary. Engaging in sex work is secondary. There are also things that can change. We know that labeling and saying somebody is something insinuates that you're labeling somebody, and that can contribute to stigma. So we've, in the harm reduction movement and other movements, it's taken a while for us to really adapt and change our language, but you'll hear me say people who inject drugs, people who use drugs, and people who engage in sex work throughout the presentation and throughout your time talking with me, and I'm happy to talk more about the meaning of that. Fun fact, Harm Reduction Coalition was actually founded in Oakland, even though most of our power and our executive director until recently was in New York and has been New York focused. There's a shift happening right now where our office in Oakland just went from 6 staff to 12. So we're getting bigger, and there's a huge commitment from CDPH Office of AIDS and providing resources for us to provide more training and capacity building services here in California. Rachel already mentioned this, and the founder is here, Rachel, but we also host the DOPE Project, which is a really well-known, effective overdose prevention program in San Francisco that specifically ensures that people who have drugs and people who are friends and family of people who use drugs have naloxone, and prioritize that over emergency responders, law enforcement, lay bystanders, and other people who are interested, because the idea is if you saturate a community with people who are likely to witness an overdose, that's really how you have the most impactful results on the opioid overdose epidemic. And then lastly, how many people have been to our national conference? Ooh, how many people are going this year? Oh, good. So there are a lot of hands that aren't raised. It's in New Orleans this year in 2 months. And we host a national conference, and it's a gathering where we learn best practices and share policy and talk about the movement in general. And we'll be hosting in New Orleans, and there are flyers in the lobby if you're interested in attending. There's still seats. You can click to the next slide. Going through. Okay, you can click one more. So I'm going to tell you kind of three broad areas that we focus on. First is that we connect and convene people. We have been hosting listening sessions throughout the state of California, talking with providers who offer harm reduction services and people who use drugs to really listen and hear and understand what the needs are. And there are all of these really incredible initiatives in California right now with the hub and spoke models, with the CDPH having more capacity to authorize syringe service programs, hepatitis C treatment and expansion of that funding this year. But if we don't understand what the barriers are for people getting those services, then what good are the services? So we'll talk a little bit more about that. We've been spending a lot of time. We'll be issuing a needs assessment later this month, and we'll make sure that everybody here gets a copy of that. Can you click? Yeah. You can click to the next one. So one of our second primary areas is really doing training. So if you click one more.
Oh, and it works now.
Oh, it does? Cool. Okay, so the second area is really training and tools, and this is what I really want to highlight for everybody in this room. How many people have ever been to the Harm Reduction Coalition website before? Okay, great. So there are a lot of resources and tools, including trainings, resource guides, how to set up a syringe service program, how to set up a naloxone distribution program, and we have all of those on our website, and they're free. So I want to make sure that folks know what resources are accessible to you. We also have staff who are available to walk through some of those resources, because sometimes reading a manual isn't enough. You need to sit and talk with somebody and talk through what the tool actually means for your community. So we have a variety of those tools. We also are relaunching our on-site training institute that's in the East Bay, and we're hosting starting next week and doing sessions for providers about sort of just some of the basics around harm reduction, because this is really, it's one thing to have a really great harm reduction program. It's another thing to have a community that is actually supportive of harm reduction and really understands the tenets and can understand if you're working in a drug treatment center, or you're working in a day shelter, or you're working in a food pantry, what the value is. And so we host these on-site trainings, and we'll also be doing national webinars on a more frequent basis, specifically for California. The last thing I'll say is every single week on Monday, we send out a harm reduction newsletter, and it's called Morning Coffee, because we sit and have morning coffee together and talk about what the trainings and resources and policy developments are related to people who use drugs in California. And right after that, we send out sort of a synthesis of the things that we've been talking about. I'll have my contact on the last slide, but you can subscribe and you get your sort of very short and sweet newsletter every Monday. The last area is really doing policy and advocacy. And we've been doing some community mobilization. Specifically in California, there was a budget request that organized syringe service programs around the state to advocate for more money. One of the things that we've heard a lot about, and you can learn more about later in a session with Melinda Ruger, which is tomorrow, is how do you sustain and build harm reduction programs if there's not available funding. So we work in collaboration with harm reduction programs across the state to try and secure some of those funding to make sure that it's sustainable. So harm reduction means something different to everybody. One of the ways I like to describe harm reduction is that it's a little different than risk reduction. We think about risk reduction as primarily the tools to reduce risk, right? So it's very public health focus. You're giving somebody a condom to use to prevent HIV. You're giving somebody PrEP who may be at risk. Giving somebody a syringe who may be reusing it and prone to a skin and soft tissue infection or to hepatitis C. Harm reduction is the approach, and that's a little different. And there's something empowering for me about this. In harm reduction, you don't have to actually have the tool, the thing, to do harm reduction work. Harm reduction is about centering people who use drugs and seeing them as an equal expert partner in developing a wellness plan for them, right? It's about facilitating a conversation with somebody that is centering their expertise, that is considering all of the different aspects of their lives that are important, and that impact their ability to do risk reduction. It's a different way of talking to people. It's a different sort of philosophy. Harm reduction with a capital H, capital R, to me, is this bigger movement. It's the thing that we've sort of been talking about this morning and in the session earlier today about just how our drug policy and our existing drug policies and law enforcement and racial profiling and all of these different structural issues really contribute and perpetuate that risk. So the harm reduction movement, capital H, capital R, is really about challenging and changing systems that work to oppress people who are most marginalized and people who are most vulnerable to structural violence. So it's a little bigger. We'll focus a little bit on the harm reduction part with the capital H and little r. And I want to play this short video of one of our friends, Orlando, and he talks a little bit about why the harm reduction approach when you're in that kind of one-on-one setting is so different.
This area was home to one of the largest skid rows in the United States. A lot of bars, a lot of drug trafficking, and it was particularly prevalent on my block. So everyone around me was caught up in drug use of various kinds, and I got caught up in it too, so, you know. I want to give you today's quote that I stole from Facebook. It pertains to my Hep C quest, and it basically says that our mission is impossible, so what are you waiting for? Let's get started. I had a long history of drug use in and out of correctional facilities, on and off of opioid treatment programs, methadone clinics, you name it, I went to it. At that point, I was so medicated all the time, and I had so many other things going on that hepatitis C was way, way down here on the list. You know, like I was, you know, more worried about getting shot in the head or, you know, going and catching a prison sentence than I was hepatitis C. But Orlando.
I don't even remember meeting Orlando the first time I apparently met him because he was so not interested in what I was doing. He had hepatitis C, he was at his methadone clinic. And then something changed. He decided, okay, now is the time to deal with this.
My plate? Yeah. Did you get a nickel? Okay. A nickel. Oh, good for Nick. Nobody asked me to, you know, piss in a bottle or have you been doing this or have you been doing that. Nobody threatened to throw me out. I just said, okay, you're here. Glad to see you. When you dictate my hierarchy of needs to me, then you're disempowering me. I know what I need, and I know what I need and in what order I need it in. You know, if you want to be a partner with me in that, that's great. You know, but if you go tell me, well, I can't do this for you because you have to go jump through these 10 hoops first, and you know we want to see how high you jump, and we don't want you to come down till we tell you to. I'm not going to respond to that. That didn't happen here. That did not happen here.
So here is the Oasis Clinic in Oakland, and this is actually taken from one of their videos. And they offer a lot of different services. And one thing that really, I love this video because I think it's really important to remember, you know, Orlando's talking about all of these different competing issues. He's talking about all of these other things, and getting hepatitis C treatment wasn't his priority. In the same way that maybe getting naloxone or maybe getting onto medication-assisted treatment may not be somebody's priority. So how do you learn what somebody's priority is? You have to ask them. So I'm going to talk a little bit about the stuff right? Everybody wants to know about the stuff and what the stuff is and that you can give to people and the value. And then we'll talk a little bit about models of services. So all of these things here, and there's probably some things missing, we consider this stuff harm reduction services. We'll start first with syringe access, which is something that we've talked a little bit about here. And syringe access, you may hear as syringe service program, syringe exchange program. Syringe access is about providing people who use drugs and people who inject drugs with the resources and tools to use safely. And that includes sterile injecting equipment, safer smoking supplies, education. And this is a nice picture of folks at Tri-City Health. And there are a couple of different models of syringe access. The first one, and we saw the baby carriage earlier in San Francisco, and this is another San Francisco program, is what we call a fixed site. Some of the benefits of a fixed site might be what? This is a brick and mortar place where people go and get the stuff that they need from the people that are going to give it to them. What are some of the benefits or some of the opportunities with having a fixed site that you can see? Yeah. Consistency. Yeah, we heard that earlier in the session that David was presenting on, is showing up and being consistent and people knowing where to go. Great. Other benefits. Yeah?
Opportunity for relationship building because of the consistency.
Yeah, because of the consistency, you have this opportunity to build relationships with people. People know where to find you, and people know if for whatever reason there's turnover, maybe they've had the opportunity to meet another person. They're not just connected one-to-one. Let's hear another benefit. Yeah. Yeah.
Oh, great. Creating like a viable third space as an inclusive space for people that can access services if they have an access or they have a question. This creates that third space.
That's right. It creates a third space, or maybe just the first space that anybody has, right? Where people are not worrying about getting arrested, where people can go and charge their phones, where people can talk with somebody, where they're treated with dignity and respect. Yeah, it can provide a third space. It may be somebody's only space. Great. What are some of the challenges of fixed sites that you can think of?
The bathrooms.
The bathrooms. Can you say more about that? It's my favorite topic.
Education with the bathrooms, washing, because if they're sick, they're not well,
Mm-hmm.
and then they need to get high, their closest thing is the bathroom.
Yeah, some people may use drugs in the bathroom. It's the only place that they can. And so there need to be conversations and need to be really thoughtful about that. Always happy to talk more about that if anybody is having that issue. Other things? Costs money, right? It's really expensive. It's expensive and it's not as transportable to meet the community needs. Sometimes places where people are copying drugs or where people are, the consistency is really important, but also what happens if there's an entire displacement or there's increased policing in one particular area. It can make it really hard to move services to really mold and bend what the community needs are, right? And there's a whole bunch of opportunities and benefits, but I think that's probably a good start. So, mobile. You could address some of those issues through mobile services. What are some of the opportunities and benefits of mobile services, particularly in rural California? I heard something. You can meet people where they're at, like literally, not just as a concept, right? Literally go to people where they are, whether it's encampments or a riverbed or a house, and being able to transport yourself there so that people aren't putting in the time, the money, the resources to travel to you. May feel safer. Other benefits? Yeah.
It can also be a place for, if you're a community, somebody can come from a different community where they're not represented for their community.
Yeah, that's a really good point. I mean, we talked about that a little bit in the rural session, bridging urban and rural, is that you don't have the anonymity in rural California where you have it, where, I can walk around the corner from where I live in Oakland And like, it's very likely that some of those people don't know who I am, you know? But if you're doing that in a smaller town, that can be hard. So having the opportunity, so you're not just parking a van and having people come to you, approaching a van, especially a marked van, means something. It tells something to the community. And we know that that's a big barrier too.
They're not going to be so afraid that the police are going to pick them up outside of the building.
Yeah, right. So it's less likely that there would be police who are kind of waiting, watching. You have a fixed site syringe service program, maybe a little bit like, you know, shooting fish in a barrel, trying to figure out like what's going on, where are the people, if we're trying to meet, you know, quotas and all that kind of stuff. So some of the limitations of mobile services, and just for the sake of time, I'll kind of rattle some off and you guys can add some later. Obviously there's not as much space. It's a little more challenging to do clinical services, especially if you require refrigeration. Not impossible. Anybody run mobiles that break down? I feel like most of the programs I know, like half of my conversations are about the van breaking down. So it's just it's a very simple thing, but it's a very real thing that can impact services and can impact consistency that was brought up earlier, right? Another model is satellite services, also known as peer distribution. Some of these are more formalized in other states around the country than it is in California. But this really means that people are obtaining the services and the supplies and going into the community and offering them to people who use drugs. Who do you think is probably best at doing this kind of service? Local folk and people who use drugs, right? Yeah. I'll tell you a quick anecdote. The most amazing outreach worker I ever had, I met and started doing services sort of informally. He was a drug dealer in the community. And we were sitting around the drop-in center one day, and his name's Big Red. It's something else now probably. And everybody was like, why don't you just give like Big Red a whole bunch of supplies? Like, we're all going to hang out with him anyway. Like at 5:45, you guys aren't here at 5:45 in the morning. And I was like, yeah. And you know, my board was like, can you like hire somebody who deals drugs? I was like, first of all, yes. Second of all, if we're really trying to make an impact, people are going to like give this clean injecting supplies to the source where people are going. If, you know, that ended up being, not only was he the best and most consistent and gave out the most syringes and it was really good at tracking data, there's a lot of like really good strengths, you know, to build off of. He also was like I did wound care for a long time and I loved it. And people were coming in with the most beautifully drained abscesses I'd ever seen. And I was like, what's going on? Like, what? Like, this is like my break from admin, you know, like, please, like, what's going on? And Big Red had gone because he figured it out with a business model that he went to a training himself to learn how to incise and drain people's abscesses and charge people $10 for it. Brilliant, right? Anyway, Big Red and I are still in contact, and he actually has a full-time job working at the organization that I used to work at and doesn't actually sell drugs anymore, which in many ways is kind of a pity because it was like really centralized and really good, but people like developed this really amazing, trusting relationship. And also as a side note, one thing we could do that's a little, I'll give you a con here, is if you are bringing, you know, doing peer distribution through people who are selling drugs, there's power dynamics, there are loan sharks, there are, you know, so I'm not saying like that's the big takeaway from this presentation, but I think it's really important to remain flexible and really kind of think, you know, outside of the usual suspects in terms of who and how you deliver this kind of work. So a couple of other aspects of harm reduction services include syringe disposal, kiosks. There's all different kinds. You can put them in parks. They have some that you can fit discreetly on top of, you know, on telephone poles. There are these sort of larger kiosks. These are from San Francisco. If you ever are looking for models of kiosks, you can reach out to me. I have millions and millions of photos of all different kinds of kiosks. And all of them work and don't work. All of them have limitations. Safer drug use. something that we don't talk a lot about, like we talk about the stuff, but this to me is the important stuff. This is talking to somebody about why they use drugs, not why are you using drugs, what do drugs give to you? What do you feel like you have most control over? You're using 3 different kinds of drugs. How do you get them? How are you using them? Are you using them together? Who are you using them with? To start to open up a conversation about understanding, like for me, maybe somebody, if I am thinking about HIV or Hep C prevention, I'm like, okay, this person's injecting heroin, they're taking benzodiazepines, and they're also smoking methamphetamine. How, like, where do I start? Maybe that person actually feels like they're using sterile injecting equipment, they have the most control over their heroin use. And it's really the methamphetamine that's hard. But they can't stop using methamphetamine until they figure out where they're gonna live, because the reason they're using methamphetamine is because they're trying to stay up at night and survive. They don't wanna get their stuff stolen, right? Like there's all of these complex stories that come out, and I wanna really reiterate that safer drug use starts with rethinking the way we ask those questions, not what drugs have you used in the past 30 days, check the box, check the box, check the box. And I know that it's really hard when you're working in systems that have eClinical Works or whatever you're using, and it's like, but they're literally boxes I have to check. And I'm making a call and a request to think critically about how you can check those boxes and ask questions that still answer those questions, but will give you something deeper. Naloxone, which we've talked about at length. I show this photo because this is a group in Montana that we're working with. They created these no-sew bags. People really did not want to carry around the naloxone bags, the zipper, and there's some that are really big and it says naloxone on them. Some people really like them because if they're using alone or like in a public restroom, they can put it out there. Like we've had people write like, if I'm blue, spray this in my nose. Like we used to do that with the Burger King and the McDonald's and all those places, so that if somebody was using, it was their only option. If they were found, they could have somebody know what to do. And these are no-sew kits, which are just like Velcro and duct tape and felt. And participants make the kits and participants distribute the kits to people. And people started carrying the kits because they weren't in those bags, and people were losing their naloxone vials and things because they were shuffled in the bottom. This looks like a wallet. So it's a little tiny thing, but it actually promotes people carrying naloxone, which is how naloxone works, right? You have to carry it to have it to, yeah. Medication-assisted treatment. This is also in Montana. It's a pretty nice room, huh? This is where they do bupe inductions. And creating a nice environment. I think, what I'd like to say, and we'll talk a lot about bupe, we have and will tomorrow, but it doesn't have to be clinical. If there's a way to sort of create a space that has phone chargers or other things for people to come back and do bupe induction and feel like they're not just like sitting in a waiting room, thinking about space. I know that's not possible in all settings, but it can make a difference. One thing I'm putting on here, AB 186 is a bill. It just passed the Assembly yesterday for supervised consumption services. It is the first bill in the United States to go this far. Next step is the governor. We've been collaborating with Drug Policy Alliance and other partners on this bill, and there's this really huge movement right now. It's restricted to San Francisco, but what I would say is keep your eye on what's happening in San Francisco. And if this is something that is valuable to your community, and how would you learn if it was valuable to your community? Ask people. That the next 3 years will sort of be a testing ground to see if this is feasible. We've seen they're feasible and they work everywhere else. So if you're in a community where something like this is feasible, I'm happy to talk to you more. But the next 3 years to build support and education around this will be really critical. This is one in Melbourne. Low threshold drop-in centers, we recognize a lot of people may not have access to housing. We've talked about the value of a blanket. We've talked about the value of socks. We've talked about the value of having a place to check your Facebook. It's the only way that you connect with people. Having low threshold drop-in centers don't have to be big and fancy, although this is a pretty nice one. But having 3 seats and a place to put your feet up and a place to put your stuff for an hour and sleep makes a huge difference if you're thinking about creating space for people. Same thing with housing first and prioritizing housing and low threshold housing placement. It's really critical. We've talked about pharmacy access, and we have some presentations coming up soon about that. And referrals, which is really, you can give a referral, but it's really about building referral networks, right? And if you refer somebody to a provider and they're not ready to receive them in the way that they are, in the way they're requesting services, that can burn a bridge. So I would just put it out there. It sounds like there's some excellent referral networks that are being built up here. So basics of how you start. I would ask everybody to think critically about who's asking for the service to begin with. How do we know the services are needed? Where are the services needed? And what is the best way to provide these services? We've talked about these different models, and people who use drugs would probably have the best answers to these questions, right? So early and often, make sure you're asking these questions in your community. We tend to start with data. That's a comfortable thing, right? But I don't know if any of you guys have had this experience where you lay out all the data and somebody's still like, but still, there's something going on there, right? There's something else going on. And you can't fight a values argument if somebody feels uncomfortable with data. So we have to move beyond that, and that requires education and advocacy. That requires talking to people about what their options are and why it's important. And it's just so key to listen to people who use drugs to plan these services. And so the sort of major ways you can do this are convening people, host sessions, pay people, talk about what other services they're accessing, when, how, when, who, and where. You could interview people, especially if you don't think in a community or people are gonna gather to talk about this. Potentially you could do paid anonymous interviews to learn some of this. If you're like, I just can't imagine putting a flyer out and hosting a session and people coming together because small town stuff, you could do anonymous interviews. And we have resources for that too at Harm Reduction Coalition. Network, thinking about where people are getting services, but also where people actually are, where they're going. It may not be, like where are like the cheapest cigarettes, or where's the best, place if they're handing out on Thursdays or handing out food. Going to other places that aren't just drug treatment and kind of the usual behavioral health services. And that means you got to get out there and you have to figure out who your allies are in your community. You have to figure out where the need is. And you don't have to do it alone. There are 43 now syringe service programs in 45, right. There are 45 syringe service programs in California, and you don't have to reinvent the wheel. There's a whole network. And lastly, I would just say, it is so critical to center people who use drugs. You have to recognize your own bias. When you think they can't show up, they won't show up, they don't know how to do this, like really critically thinking about how you're perpetuating people not participating. Second is to reframe expertise. We hear a lot about incentives, like you gotta incentivize people, you gotta incentivize. I would love to offer reframe and say you gotta pay people because they're experts, right? You have to pay people, pay them well, ideally not in gift cards and in cash, because they're consulting for you. And you have to build structures to promote and maintain that point of view and thinking outside the box. You're not going to hire people who use drugs or who have lived experience or currently using drugs if your policies say you drug test people every 3 months. So there are some of those things that have to be worked through. And the last thing I would just say is skills building and leadership, because this is what that does.
Fortunately, he was one who we managed to treat with interferon, get him up to a meaningful dose, and keep him there. And lo and behold, Orlando was cured. Boom. He was normal.
The minute I found out that I had a virus, I wanted to let other people like myself know. A lot of them just weren't aware of the facts. So when I came here and I started being educated about the facts, I didn't keep those facts to myself.
You can't beat what you don't treat. You can't beat what you don't treat.
I told my peers, did you know about this meeting? Did you know that there's treatments? Did you know how it spreads? A lot of people were just in the dark about it. Nobody had talked to them. Nobody had talked to them. Not at the emergency room, not in the correctional department, not anywhere. They'd never had this kind of conversation.
It doesn't matter what state of chaos you're in. We see people who scheduled their, Oasis Clinic visit months in advance, and we also see people who kind of rolled in off the streets and they heard that it's Hep C and pizza. And we like them all. You know, it doesn't matter to us.
This is a wake-up call, it's just not for you.
So lastly, I would just say I'll be here today and tomorrow. I'm happy to share more resources, but I would just say, reduce risk, and that's step one, and ultimately this is a long game, build power with people who use drugs so they can carry on this work. Thanks.
Plumas County Public Health Agency, growing healthy communities.